Good afternoon, everyone. I would like to welcome you to today's virtual learning community on medicated-assisted treatment for our final event in a three-part series that has been presented by SAMHSA's GAIN Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's webinar is entitled Medication-Assisted Treatment in Drug Courts Virtual Learning Community, Introducing the National Association of Drug Court Professionals Medication for Opioid Use Disorder Toolkit. The two presenters are Dr. Douglas Marlowe and the Honorable Craig D. Hanna. I will introduce them in just a few moments. We will also be holding an hour-long discussion following the webinar today, which in addition to our two presenters will also include Sophia Lombardo, a certified peer recovery specialist. I'm Maureen McLeod, and I'm a Senior Research Associate at Policy Research Associates. And before we start our presentations, I have just a few housekeeping items to review with you today. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or questions in regards to the technology, we would ask that you please type them into the Q&A pod that should appear on the right side of your screen. We will address as many of your questions to the presenters as time permits during the webinar, and we will follow up with additional questions during the discussion session. We will also be conducting a brief poll and appreciate your participation. When you see the poll pop up on your screen, please enter your responses, and I see the poll has popped up. Thank you. This webinar is being recorded, and slides will be disseminated via the GAIN's listserv following the webinar. We will also notify all registered participants when the webinar recording is posted to SAMHSA's YouTube channel. A certificate of attendance will be available for download at the end of the webinar. Please note that this certificate is for personal portfolio use only, and it is not used for CEU credits. There is ASL interpretation for this event. To view the ASL interpretation, go to Layout in the upper right-hand corner of the screen, then select Hide Non-Video Participants. Then change the layout view to full screen. Finally, select View All, and that icon looks like opposing edges of a rectangle. So the two interpreters for today are Katie Lambie and Mareke Larson. So thank you, Katie and Mareke, for joining us today. There's also live captioning for this event. To view the live captioning, select the Accept button in the Multimedia pod located on the lower right-hand corner of your WebEx screen. The color contrast of the live caption pod can be changed as needed. We recommend the high contrast style for best visibility. The agenda for today's event is presented here for your review. John Berg, a Senior Public Health Advisor with SAMHSA Center for Substance Abuse Treatment, will provide some opening remarks, followed by presentations by Dr. Marlowe and Judge Hanna. So I'm going to turn it over to John Berg for his opening remarks, and welcome.
Dr. McLeod.
And John, oh, there you are, John, okay.
Okay, you can hear me now?
Yes, we can.
Okay, great. Thank you, Dr. McLeod. Welcome to today's Virtual Learning Community, or VLC, Medication-Assisted Treatment in Drug Courts, Part 3, introducing the National Association of Drug Court Professionals Medication for Opioid Use Disorder Toolkit. We appreciate you taking the time to participate today. SAMHSA is interested in promoting policies and practices to lower the risk of overdose for persons with opioid use disorder who are or have been in contact with the criminal justice system. As I've noted previously, there is overwhelming evidence that medication-assisted treatment is an effective intervention for addressing opioid use disorders in criminal justice populations. research indicates current high rates of opioid use disorder among drug court participants nationally, but there are gaps in the availability of medication-assisted treatment in many drug court programs. For many years, SAMHSA has led the way and encouraged SAMHSA-funded drug courts to provide MAT and required that they not deny access to drug court program to any eligible client for his or her use of FDA-approved medications for SUD treatment. Since fiscal year 20, SAMHSA began requiring funded drug courts to implement MAT with access to FDA-approved medications. They're no longer just encouraged, but it's required. Therefore, if drug courts are interested in future SAMHSA funding, attending this VLC will be very helpful with understanding effective implementation of an MAT program. It's been our pleasure to coordinate this webinar with a great partner of SAMHSA, the National Association of Drug Court Professionals, or NADCP, to help introduce their Medication for Opioid Use Disorder Toolkit. The toolkit was developed with funding from the Office of National Drug Control Policy and presents practical tools and resources for treatment court teams and will assist teams in their efforts to make critical connections with local jails and treatment providers. The emphasis of this webinar will be on fostering partnerships and developing agreements to ensure access to community-based treatment services and supports for drug court participants. We are excited to host part 3 of this VLC with 2 experts in the criminal justice field. I want to thank our presenters today, Dr. Doug Marlowe and the Honorable Craig Hanna, for sharing their knowledge and expertise with us. We look forward to a great discussion following today's presentations. And as always, I would like to thank the Gaines Center staff for their work in developing and facilitating today's VLC. So with that, I would like to turn it back to Dr. McLeod.
Thank you so much, John, for those great remarks. I'd like to take a few moments to introduce our 2 speakers for today's webinar. Dr. Doug Marlowe is a senior scientific consultant for the National Association for Drug Court Professionals and a senior science and policy advisor for alcohol monitoring systems. Previously, he served as the Chief of Science, Law, and Policy for NADCP, the Director of Law and Ethics Research at the Treatment Research Institute, and as an adjunct associate professor of psychiatry at the University of Pennsylvania School of Medicine. Both a lawyer and a clinical psychologist, Dr. Marlowe studies the impact of coercion in substance use treatment, the effects of drug courts and other rehabilitation programs for persons with substance use disorders involved with the justice system, and behavioral treatments for persons with substance use disorders and justice system involvement. He's a fellow of the American Psychological Association and the College of Physicians of Philadelphia, and has received proficiency certification in the treatment of psychoactive substance use disorders from the APA College of Professional Psychology, and has been designated a Master Addiction Counselor by the National Certification Commission for Addiction Professionals. Dr. Marlowe is widely published on the topics of correctional rehabilitation, forensic psychology, and treatment of substance use disorders. He's the editor-in-chief of the Journal for Advancing Justice, serves on the editorial boards of Criminal Justice and Behavior and Drug Court Review. And we're very happy to have you today, Dr. Marlowe. So a graduate of Canisius College and the University of Buffalo Law School, the Honorable Craig D. Hanna began his legal career as an assistant district attorney in the Erie County District Attorney's Office in Western New York. He now serves as the Chief Judge of the Buffalo City Court and as the supervising judge of the 11 city courts in the 8th Judicial District in Western New York. Judge Hanna achieved national fame as the presiding judge of the first opioid intervention court in the United States, which was established in May 2017. He's been featured in such major media publications as the New York Times, NBC News, MSNBC, the Denver Post, and HBO Vice News. He's lectured internationally on treatment courts and on the topic of breaking the shame and stigma of addiction. Judge Hanna proudly professes 23 years of clean time and tells participants in his court that the only difference between them is the length of the clean time. At the State University of Buffalo Law School, his alma mater, Judge Hanna lectures in trial advocacy and procedure. He's a member of the prestigious Franklin H. Williams Judicial Commission on Racial and Ethnic Fairness. So thank you also, Judge Hanna, for joining us today. So we see that the poll results are in, and I just want to share a few observations about who's participating in today's webinar. So it appears that we have actually fairly evenly distributed from urban, suburban, and rural areas with a slight advantage to the urban areas. And in terms of professional affiliation, it looks like we have fairly equal representation from the judiciary, probation, parole, community-based corrections, governmental entities, and community-based treatment providers. So I want to thank everybody for joining us for today's presentation. Now what I'd like to do is to turn the presentation over to Dr. Marlowe, who is going to begin the presentation by introducing the toolkit that he has been so intricately involved in its creation. Now it's all yours, Dr. Marlowe.
Thank you, Maureen. Thank you all for joining. As Dr. McLeod said, I've been asked to give a relatively brief, about 20-minute or so overview of NADCP's new toolkit with practical resources for adopting medications for opioid use disorder in treatment courts. But we should have plenty of time in the second hour for those of you who can stay with us to delve into greater detail. I'm basically going to hit the high points here. Please note that the purpose of the toolkit and today's presentation is not to provide a basic primer on MAT, on what the medications do, on how they work, or even frankly to try to enlist drug courts to use them. The toolkit is really there for drug courts who have already been trained on the medications, are familiar with them, and are preparing to and willing to adopt them. And we're giving them the tools they need in order to bring those procedures into their program. So first, a disclaimer, note from our sponsor. The toolkit was sponsored by ONDCP, the Office of National Drug Control Policy, and the views and opinions are those of me, and not necessarily the position of ONDCP or the Executive Office of the President, although they do represent the considered opinions of the National Association of Drug Court Professionals. So why do we need this toolkit? Why should we be endorsing medications in our drug courts? Because 15 to 30% of adult drug court participants in the United States have an opioid use disorder or are reporting, have been determined to have opioid use as their primary issue that brought them into the program. We have known for decades that participants with opioid diagnoses have lower successful completion rates in drug courts. They have higher recidivism rates. In other words, they have poorer outcomes. And we have pretty alarming evidence that there are high rates of overdose deaths. And most of these studies are really long-term studies of drug courts in which participants were in the drug courts in the early 2000s. And now we're looking 15 years out and finding, substantial overdose death rates for participants having left those programs. And this was during when heroin was the primary opioid on the street. Now with the pharmaceuticals that we're struggling with and fentanyl and the like, the rates could be higher. There's also quite good evidence that when drug courts adopt the full range of FDA-approved medications and they do it the right way and follow best practices, we get substantially better outcomes pretty much in all areas. So we have good reason to be doing this. The toolkit has essentially resources, memoranda of understanding, other documentation that programs can use to set the policies and procedures for the use of medications in their program. The first is a partner agencies agreement. This is an MOU, memorandum of understanding, between the various agencies working in the drug court, the court, probation, parole, prosecution, defense, treatment coordinator, agreeing about what the ground rules are in the program, what the various rights and responsibilities of participants and of various members of the drug court team. The goal here is to keep team members working in their correct lane, not working outside their area of expertise, not undermining each other's efforts, and making sure that the program is giving medications the best opportunity for success. The next material in there is a medical practitioner agreement. Generally, most drug courts do not have medical practitioners, physicians, nurse practitioners, or physician's assistants on the drug court team. Often they're not even staff in the primary agencies working with the drug court. Very often these are other practitioners in the field that are being enlisted to treat patients. And so there is an agreement between the drug court team and those providers about what the mutual rights and responsibilities and duties are. The critical issue being that it is the medical practitioner that makes medical decisions, and it is the drug court team that makes monitoring decisions, that makes other best practice decisions, that is responsible for medication adherence and compliance, not to undermine that, but to improve upon it. The participant agreement is, as it suggests, an agreement between the person receiving MAT and the drug court, laying out their rights, what they can expect, what protections they can receive, and to what responsibilities the drug court has to them, but at the same time, what they are required to do themselves as part of this agreement in order to receive the medication, in order to do that so in the context of the drug court program. There's a participant brochure. This is something that is meant to be widely available to participants, their loved ones in the program, written in very low, understandable language, 6th grade reading, what these medications are, making it clear that participants are allowed to use them in the program, that they're not required to get off them as a condition of graduation, that they're safe, they're effective, that the program will help to facilitate that, and letting them know what they need to do in order to get more information. There is then a letter from the drug court to medical practitioners in the field. Many drug courts will say, well, we don't have any physicians available to us. There are no physicians in our community. And that is actually usually not the case. They usually are there. The drug court simply doesn't know about them, and vice versa. And so there are directions for how to contact medical societies, local hospitals, online locator services to find out where there are physicians that are certified, for example, to do for buprenorphine prescriptions or for methadone facilities, and letters that the drug court can send out to those agencies, letting them know about the drug court, what the drug court is, dispelling a lot of common misconceptions. There are views out there by many members of the medical community that drug courts are against medications, that drug courts undermine it, they punish participants for it. While that is true of some drug courts, it is not true of most drug courts. And so dispelling some of those myths, those misperceptions, making it clear that drug courts are a rehabilitative option, that they will accept and follow the medical advice of the practitioner, and invite them to come and learn more. And finally, a letter to jail officials. Many individuals in drug courts may spend some time in pretrial detention prior to entering the drug court. They may get jail sanctions while they're in the drug court, and many of them are frankly terrified, for understandable reasons, about being withdrawn involuntarily from those medications if they do serve a jail sanction. And therefore, there is a letter from the judge to the jail officials inviting them to engage in a dialogue about the continuation of these medications for both safety reasons and, frankly, emerging legal case precedent reasons that jails and prisons may have no alternative but to maintain those medications, at least based on emerging precedent. So these documents are available. They can be downloaded in a Word format so that they can be modified, the templates, by the programs, so that for your own use, to put the name of your program in and the like. I don't know what I just did here. Okay. I'm not going to go through all the materials. It would take way too long in 20 minutes, but what I want to do is discuss with you what runs through all the various templates, what the general principles are that are reflected in all the documents, so you can understand what's being agreed to and what's being established in these policies and procedures. The first is that treatment courts, drug courts, are committed to both evidence-based practices shown to improve outcomes while also protecting participant welfare and public safety. It's both. Therefore, we will provide evidence-based treatments, but we will also do whatever other monitoring and additional complementary services are necessary to ensure that those treatments are used safely and appropriately. It is not an either or, it is a both. There is an affirmation in all these documents that medications for opioid use disorder are a component of the generally accepted evidence-based standard of care. In other words, if you're providing treatment for opioid use disorders with medications not being an option, a consideration, part of the calculus of decision-making, you are violating the medical standard of care for the treatment of opioid use disorders. And the documents simply say drug courts recognize that. We are required to recognize the standard of care, and we are required to follow it. And that's what emerging court cases are basically telling us we must do. Participants have a right to medications when they are prescribed by somebody who is duly, lawfully entitled in a jurisdiction to prescribe the medication, has personally examined the participant, and will continue to manage the case going forward. That person must be an active prescribing and treating physician. There is a right to a choice of medical providers. Why? Because when participants can choose their own medical providers, outcomes are better. That's what the research tells us. Unless the drug court finds, the judge finds, based on medical evidence, that the care being proposed or provided either falls below the generally accepted medical standard of care, the physician is engaged in practices below what are considered the standard of care in the medical community, or are engaged in practices that will directly threaten the patient's welfare. At that point, the team is not only entitled to, but really has a responsibility to override the physician's management of the case. That doesn't mean override their judgment. It means find a second physician, a second opinion. Absent such an explicit finding, the court should be giving deference to participants' preferred provider, especially if that provider has already been treating them before they came to the drug court. The selection of medication, dose, and duration are medical decisions. Telling somebody what medication they can and cannot have is a medical decision. Therefore, if a court is telling people you can't have a particular medication and non-medical people are making that determination, they're engaged in medical decision-making. If you are telling people they can only have a certain dosage, that is a medical decision. If you are telling people they must get off the medication before they can graduate from your program, requiring people to get off a medication is a medical decision and legally requires a physician to make that decision or another medical practitioner. We are simply affirming what is already the law in this area. Now, if the court thinks that the physician is engaged in inappropriate practice, that the amount of medication being recommended is too much, the patient's being maintained too long, you are not without recourse. The appropriate thing to do is to get a second opinion. That's what we all do when we don't trust the medical opinion of the first physician. We don't decide that we'll make the decision instead of them. We get a second medical opinion. And in the course of all of this monitoring, use immunity attaches to all the procedures being done. Use immunity means the information that's being obtained for purposes of managing the case cannot be used to prosecute a new charge against the individual, to bring a technical violation against them, to augment their charges. You are going to be engaged in extensive monitoring of these people in order to improve their clinical outcomes. What's the participant's responsibility? The participants must provide contact information about the medical provider to the drug court team and sign all required releases of information necessary for the provider to speak to the team freely about the participant's medical treatment. Freely means relevant information that's relevant to the management of the case. Without such a release of information, that participant is participant is engaging essentially in behavior that is not approved by the drug court. The medical provider themselves must execute an agreement with the treatment court, understanding what the medical provider's responsibilities and rights are. The medical provider makes medical decisions, but the treatment court makes monitoring decisions, other consequential decisions. And in order for the treatment court to do its job, the physician, the medical provider, must communicate with the court what's going on in the case. And so there's an obligation to share information commensurate with HIPAA and other legal obligations. And any physician who says, I will not share information with the court, is not an appropriate physician to receive and treat a drug court case. They're not qualified or competent or confident in their ability to work with this population. Participants can and will be subjected to treatment court monitoring. They will be monitored when appropriate to make sure they're using their medications safely, effectively, and legally when necessary. We're not going to put all kinds of burdens on them for no reason, but if there's reason to think the person might misuse the medication, then we might do observed ingestion of the medication. We might do random pill counts to make sure they still they're not using more pills than they should. We might use medication event monitoring devices that tell us how many pills have been taken out of the medication vial. We might be doing prescription drug monitoring program inquiries to make sure participants are not getting medications from other providers. Not only can we do that, when there's reason to think it's necessary, we must do that, and there will be consequences if the participant violates those monitoring obligations. There is the critical distinction all drug court professionals are aware of between proximal and distal infractions. If you've gone to any training on best practices in drug courts, you're already familiar with this. A proximal infraction is an infraction, a willful infraction of a responsibility in the program that the person was capable of following the rules and essentially chose not to. Participant misuses the medication, tampers with a drug test, gets another unapproved prescription from another provider. Those are proximal infractions, and they will receive substantial consequences for that. However, those consequences will not include removing them from the medication. We don't punish people for misuse of medication by taking them off the medication, because taking people off medication is a medical decision and requires medical expertise. We might, however, do jury box monitoring. We might do brief jail sanctions. We might do curfew monitoring. We might do journaling exercises, the other kinds of consequences we apply in our programs. On the other hand, if somebody is receiving these medications and they have positive drug tests, opioid drug tests, we do not sanction and will not sanction continued opioid use until and unless the treating physician has said this person is at their therapeutic dose, because these doses are usually titrated upward over time. They are at their therapeutic dose, and they have been reliably clinically stable for a long enough period of time. Typically, it's going to be 60, 90 days without cravings, without withdrawal symptoms, without anhedonia, the inability to experience pleasure, without depression, anxiety, these other associated symptoms of their addiction. We don't punish people because they have not yet reached a therapeutic dose or a therapeutic clinical level. That's true for all drug court sanctioning. We don't sanction people for their illness. We sanction them for willful misconduct. If, of course, a person is diverting the medication, selling it, trading it to other participants, that is grounds for dismissal from the drug court, and whatever other consequences people will face for an unsuccessful termination. If the judge finds either or the judge finds, I should say both, that the diversion posed a substantial threat to another person and is reasonably likely to be repeated. Okay, if that happens, then the court shall dismiss a participant because that person is a threat potentially to other participants in the program. That is untenable. If they engaged in behavior that was a threat to someone else, if it's reasonably likely to happen again, they shall be removed from the program. If only one of those criteria or neither are met, then it would be more of a permissive issue. Treatment court responsibilities. The treatment court shall agrees to engage in proactive screening and referral to identify people with opioid use problems who may need MAT. We don't wait till someone requests it. We don't wait until somebody is failing in drug-free counseling before we make a referral. We proactively screen, identify cases, and make referrals if the participant wishes one. We work to motivate those referrals by engaging in psychoeducation with the participant. Many of them have the wrong idea about these medications. We may have to meet with their family and significant others because they have misconceptions about the medications. We may do communal education where the judge talks about these medications in court so that we're creating an acceptance of these medications in the milieu. We will employ monitoring and consequences pursuant to best practices. Already discussed that. The treatment court is responsible for guarding against misuse and diversion of the medications. The treatment court will look for peer support groups that are open to medication for opioid use disorder and prepare participants for stigma and rejection they might experience and often do in the 12-step community. We will identify peer mentors or recovery support specialists who have experience with substance use histories, often medication themselves, often criminal justice involvement, to help them negotiate the world of treatment, the world of the drug court. We will go out of our way to seek funding for these medications through block grants and appropriations, through federally qualified health centers, through drug pricing programs through the federal government that mandate Medicaid covered medications to be available at low costs in certain communities, Medicaid and the like. We will engage benefits assistance to help our clients locate these medications. And we will go out of our way to recruit medical providers to work with our patients using some of those materials I pointed out that we have in there, letters trying to get people to come and work in our programs and help us. The medical provider, I realize I'm short on time, the medical provider must execute an agreement with the drug court team and share the minimum necessary information. What information must they share is listed in the documents, the kinds of information they will ordinarily share with the drug court team. They will provide care consistent with generally accepted medical practice. If the judge finds their care is substandard, they shall not treat drug court participants. They will respond to inquiries from staff within 48 hours, and if it's an emergency, they will do so ASAP. They will furnish emergency instructions to staff, to participants themselves, their significant others. This is what you do in a medical emergency. This is what you do if there's a medication side effect, if they take too much of the dose. They shall do prescription drug monitoring program inquiries. They will deliver overdose prevention and reversal to our participants. And I think I jumped one. They will let our team know whether our participants are clinically stable and at a therapeutic dose and for how long. So then the team will know whether drug use, opioid use, is itself a proximal or distal infraction. The medical provider won't decide whether it's proximal or distal, but they will let us know whether that person is or isn't clinically stable on a regular basis. And regular basis means certainly in advance of every team meeting. Critical takeaways, and I'll stop. The provider and the participant make medical decisions. Drug court teams do not make medical decisions. They're not qualified to, and they are engaged in unethical practice when they do so. That includes saying what medications people can have, how much they can have, and how long they can have it. The treatment court team makes the complementary treatment and supervision decisions. What does that mean? If somebody needs moral recognition therapy to think more appropriately about how they're handling their medications, then the drug court team will send them to MRT to deal with some of those irrational cognitions. They will continue to manage the other aspects of the case. The medical provider will share relevant information and coordinate care with the team with use immunity for that information. The critical distinction between proximal and distal infractions. We don't punish people for using opioids when they're in drug court because they have an opioid addiction, until and unless they are clinically stable and at their therapeutic dose. Otherwise, we are sanctioning medication misuse, not failure to reach symptom resolution. And active facilitation of medications is the standard by which we judge the success of all drug court team members. And now I'm going to turn the slides over to my good friend and colleague, Judge Craig Hanna. Thank you.
Thank you, Dr. Marlowe, and thank you all the attendees for being here today. Dr. Marlowe gave you a very good overview of medication-assisted treatment, and now I'm going to give you an overview of medication-assisted treatment in action. Again, I'm going to try to go through as much as I can, but as the doctor stated, we're going to have a question and answer period towards the end. So some things I may seem like I'm flying through, but we're going to make sure we have time for a meaningful and engaged dialogue at the end. I want to go over the background of our program in Buffalo, also ways to get started, linkages to your other treatment providers and community mapping, partnerships with the prosecution and defense bar, which is noted in their toolkit, educating the law enforcement and connecting with jails, benefits and use of medication-assisted treatment. Basically, why would you use MAT? And I'm going to use MAT periodically through this lecture as an acronym for medication-assisted treatment. Access to MAT, linkages to the recovery community, which is critical. I'm going to talk about that briefly, then we'll get into it at length. Sometimes you need people to actually take your message and break it down in a format where our user or where our participants can actually understand it better. Sometimes we may get caught up in our verbiage, our technology, and maybe, as the doctor said, get caught up in our positions and title, and we got to get out of our way and stay in our lane. And that's the benefit of the recovery community and peer advocates, because they can take our message and put it in a format where it's easily comprehensible, and our clients can actually take it and use it to the best of their ability. Obviously, funding is critically important, and we'll talk about that too at length. Let me talk to you about the Buffalo Opiate Intervention Court. Let me talk to you about Erie County, where it's actually located. Erie County is a pretty big county. It's kind of like the sixth borough if you're from New York area. It's about 1.2 million people. It's on the borders of the Lake Erie, home to Niagara Falls, and it borders Canada. The drug of choice of our justice-involved population includes opiate and heroin, benzos, and methamphetamines. So I'm going to move on for time's sake and move out of here. And I think Dr. Marlowe hit the nail on the head, so I'm going to emphasize it. And they say the best way to make people actually remember something is by repetition. As a treatment court, our primary purpose is to help people, or at the very least, not hurt them. I'm going to read that again. Our primary purpose is to help people, or at the very least, not hurt them. Yes, when someone is on an opioid, they may use at some point. And again, I like to liken it to myself. And I use this analogy as a joke, but it's not a joke. I'm supposed to cut my cholesterol down, and I'm not supposed to eat steak. And whenever there's a good steakhouse in any town, I tend to check it out. I say that because sometimes we make decisions that are not best for us, even though we have the information. Our job is to make sure that when our clients do have that, let's say, a relapse or a hiccup, we make sure they're given the assistance so they can do well. And again, Dr. Marlowe said this too. We don't punish use. We punish negative behavior. You do not sanction use. You sanction behavior. When someone's in recovery, and we always like to say this, when you're in recovery is not 2 weeks, it's not 1 week, it's not a year, it's a lifetime event. And sometimes when someone makes a mistake, we have to make sure that we change the process. We never blame the client. Sometimes you have to reevaluate the process that you're using and do another methodology towards their treatment. And again, I'll talk about that greater in detail. The purpose, as we said, is to reduce incidents and deaths. Why are we treating this drug different than we treat other drugs? It's because the potency, and I know we talked about that earlier, is that when the introduction of the synthetic opioids have really added to why we need to handle this differently and why medication-assisted treatment is valuable. You want to cut down on recidivism. That's the whole idea. In any partnership, when you talk about law enforcement, we have to partner with our agencies. The whole idea is to cut down on repeat people recidivism, and most importantly, you save money and you save tax dollars by when you get people into the criminal justice system, you touch them immediately, and then you make sure they don't come back. You can increase completion rates, and most importantly, you have increased functional outcomes: abstinence, employment, housing status, social stability. The whole idea is that you want to make sure that the client comes out of the court in a much better place than they come in. Rapid integration approach, and I'll talk about this briefly, but then I'll get into it later. Um, on a sequential intercept model, where all courts are a number 2, but we want to make sure that we put it like 1.5, if that's our category. Soon as they get in the courtroom, you want to make sure they get the treatment that they need. We don't want to wait on the back end. You want to make sure they get there, they get the treatment that they need, and we cut down on the red tape and to make sure they can have it. As their doctor alluded, once we get our clinicians on board, we want to make sure we break down the biggest barrier to treatment, and that's the time. Our clients have probably been going through this over years where they've been seeking treatment and seeking recovery. For some reason, some medical reason, maybe some time or transportation reason, the day that they really wanted to access to treatment, they weren't able to get it. So our job is to make sure we take that correct away and make sure we get them into treatment as quick as possible. And again, we'll use a rapid integration approach. I won't dwell on this because of time, but I will say the main thing is that we have them interview immediately. We make sure they meet with their treatment providers and make sure they meet with our recovery community, and we'll give them the best treatment that works for them. And again, as the doctor says, we have to stay in our lane, and it's their choice, and they choose the best treatment that works for them. This is what we do in Buffalo, and I'll go through this quickly because I want to get into how we can do this on a more grander basis. You divert participants at arraignment. You really do have to screen them immediately. You have to make sure the second your system touches these individuals, they're diverted into the treatment part. You want to place them in treatment within 24 to 28 hours, or 24 to 48 hours. We, and I like to say this, have a embarrassment of riches because we started a program and individuals in our recovery community and our treatment community came aboard immediately to assist us. So now we can get people in treatment within 24 hours. You have to hold off on the criminal charges because the main thing is we're trying to treat the whole person and get the person better stable. So when they're back in the community that they won't reoffend. By playing by Vegas rules, that's meaning, and I'm glad Dr. Malo stated, is that when people do have a hiccup, and we do like to call it hiccup as opposed to a use, when people do have a hiccup, you want to make sure that it stays there and it's not held against them for any accountability purpose on the criminal file. You want to make sure that they can come to you and tell you that they need help and they need assistance, and they won't be trying to hide something from you. We link them with ancillary services. I'll talk about that quickly. That's just hook them up with other things. Transportation. Transportation, especially if you live outside of a urban community, could be the biggest bar to treatment and the biggest bar to the recovery. So you want to make sure they're linked with transportation to and from court, to and from treatment, to and from their jobs. And we have to make sure that that transportation is reliable because we doesn't want that to be held against them. We have a curfew. We do have a curfew because a lot of times people engage in activities that are less than honorable, and if I'm using my words as diplomatically as possible, it's at night. So you want to make sure they have an active day. Their day is full of enrichment activities, and then they have a curfew at night to make sure they have enough time for refreshment and sleep so they can start over again. You do have to have drug testing. That's just random drug testing to make sure that they're being held accountable. We do have to have wellness checks. Wellness checks is to make sure they're following through the dictates of the program. We all know what staffing is, so I'm going to skip staffing. We engage in face-to-face contact. And I think I'm glad I had this still in here. And I'm glad Judge Hennigan, who's actually presiding over our opiate court, I want to give her a shout out right now. We switched to virtual, and we had to make a major pivot during the last year and a half. But the virtual was still gave us the opportunity to engage in face-to-face contact with our individuals. And it's beautiful because we don't want to have them say they don't have the services or the support that they need. Because our job, and I'm glad we're going to stick to this topic of staying in our lane, is to support them and give them the support that they need, and also to give them the encouragement if they do stumble and fall. You do have to have case conferences to make sure that the case is proceeding. And I'm glad this is the last one. You have to have peer advocates. Again, as well as we think we're trying to deliver our message to individuals, and as well as we think how thoughtful our approach is, sometimes you need someone to stand in their shoes to tell them, listen to these individuals, and this is how you navigate this system. The beauty of peer advocates, because they can break it down, as I said before, break your message down in a way that everyone can understand. Sometimes we may get caught up in our verbiage, sometimes we may get caught up in our phraseology, but the main thing is our message can be given to our individuals so they can be successful. I'm going to go through this because I don't want to make sure I can tell everyone how this thing can be replicated, because this definitely can be replicated in every part. We're dealing with people in crisis, high risk and high needs. So the first thing we need to do is find out what's in our community. You got to have several community partnerships and agencies that already do it. And the best thing, if you do community mapping, you can find what other agencies to do it, so you don't have to reinvent the wheel and bring them in. You have to meet and get buy-in with your prosecutors and defense bar. You have to meet and get buy-in from your defense bar and prosecutors. The reason is we have to have broad selection base. You need people everywhere from misdemeanors to felonies. Anytime someone might be using the criminal justice system to support their use, we have to make sure they have the benefit of getting the service that they need. So a lot of times you have to realize and talk to your prosecutors about, you're going to need some pretty substantial felonies, burglaries, home invasions, sometimes break-ins in people's home, which is probably the most important thing, and probably sanctity of your home. You do need those type of cases too, because you need those individuals to come in the program so they can have the tools so they can live a more successful, productive life. You definitely need to meet and promote and have buy-in from law enforcement and the jail community. You need that immediately. We have to have our officers with the mindset when they bring people in that they're coming in to get help, and not that they're going to get a slap on the wrist. The help is that once they get connected to treatment, especially medication treatment, that they will be a more productive citizens. Also with jails, if your jails uses injectable naltrexone like we do, sometimes after they meet with the medical technicians in the jails, they can also get linked to that immediately as well. And we do promote that as well. I didn't say that, but I'll say it now. Our MAT consists of methadone, buprenorphine, and injectable naltrexone. And again, as Dr. Marlowe said, it's not our choice, it's the client's choice, and they meet what's best for them. While I'm talking about that, and then I have to give SAMHSA a shout out, through the benefits of a SAMHSA grant, we do have a treatment van that is actually located through one of our treatment providers that's parked outside of our courtroom. The reason why I want to highlight that is that for their first meeting, after they meet with our judge and they meet with the case manager, they actually go outside, meet with the clinical technicians, and have a telemedicine visit with the doctor who may be prescribing the medicine, if that's what our client believes. And that's through a SAMHSA grant and a partnership with one of our CBOs or one of our partner agencies. So the beauty of partnering is that we can connect individuals with the assistance that they need by partnering with other agencies. And again, I'm going to skip through because I'm running behind. Obviously, you got to incorporate your medical providers, seek funding, incorporate benefits assistance. This is what Dr. Marlowe was talking about earlier. And again, I'm using this as an example. We have a Medicaid ombudsman on site. And I say it's on site because if you hear stories from our recovery community about the red tape that some of our clients are going to by not having the proper ID, not having everything in their hand when they wanted treatment. This is their day that they want is treatment and they want to start their recovery, is that we have everything on site. So we do have the Medicaid ombudsman on site too. Transportation, I said that before, you need transportation to and from home, to and from court, to and from treatment, to and from their medical providers. We have to make sure that transportation is not a bar to treatment, especially as I looked at half of our participants are from suburban and less than urban areas. We have to make sure that that treatment is available to people. Okay, so let me move it here. Again, I talked about this before. You find out what's out there. Find out what's out there and connect it. And you always see this here, you got to have defined roles and stay in your lane. Synergy. There's a lot of other programs that are working out there that's doing things similar, so you make sure you bring them together. I'm going to skip here the family resources. You do need someone from family resources. I want to say this, and I think I'm not overstating that the family goes through this process just as much as the participant. And the family needs to be connected with resources too. So I'm going to direct you, if you have the toolkit, to the partnership agreements on page 4, and they'll give you an example how to connect with other agencies. Invite agencies to your planning meeting and stay open to change. We began our program and we made a major pivot. We began our program with methadone only, but as the other agencies saw what we did and had to buy into what we're trying to do, they came to the table and offered us their assistance too. So now we have the 3 traditional medically assisted treatment, as I stated before. Buy-in from the defense bar, we talked about that, so I'm going to move through that quickly. But without the buy-in, you don't have clients, you don't have referring, you don't have any program. So you do have to get buy-in from the prosecutor and defense bar. The easy thing about it is cutting down on recidivism. Obviously, the defense bar wants their client to come out of there, I guess, as unscathed as possible. But the prosecutor's job is to make sure they cut down on recidivism. And you do that as by giving people the tools to be successful. We talked about this briefly, but you have to have broad eligibility standards. Sometimes prosecutors only want to limit their treatment court to, let's say, I'm going to call it low-hanging fruit, as I say, in nonviolent offenses. Sometimes it's the cases that they believe should go there. But we should make sure that anything that's eligible to go to a treatment court should go into a treatment court, because a lot of our crimes are based upon people that are self-medicating. And I know we didn't talk about it, and we'll say that to another lecture. They're self-medicating to hide some latent trauma that might be in their lives. So you want to make sure that you give them the tools necessary to be successful, and then that will cut down on them coming back. I'll skip through the defense bar buy-in by saying this, is that we need the defense bar to know that all the decisions that we're making are treatment-related decisions. We're not making any decisions that's going to negatively impact their clients. And that you do have to explain that to your defense bar, because your client is very open with you. They're talking about their use, they're talking about places that they were, and they're talking about all this for prosecutor being around. And I believe Dr. Marlowe stated this earlier, we can't have that held against them. The whole idea is that they can come in, share the information, and we can make a medically or the best determined treatment for them based upon the information that they provided us and that we provide to the treatment providers and to their clinical and medical staff. All right, we talked about this, so I'm going to move through this, but I will highlight what we have in Erie County. In Erie County, we have Project Blue. Project Blue is a partnership that we have with our local holding cell, that when individuals are in custody, let's say they're sentenced to a short level of time, and on their way out, they can actually get screened to go into a treatment-based program prior to them leaving the jail. And I brought this out and I highlighted how you can partnership with other agencies. So when they're in jail, they can start their treatment and recovery through counseling. And then once they leave, they can continue it by partnering with our program and other agencies. And I was remiss. If you need additional information about the partnership agreements with law enforcement, I want to direct your attention to page 5 of the toolkit and also Appendix F. Medical providers, you may say you don't have these in your community, but I say that you do. A lot of times you just have to canvass your community to make sure that these are happening, especially with buprenorphine. I know it's in the toolkit, so I'll talk about it briefly because the time is growing late. In the toolkit, there's ways that you can get waivers for eligible doctors to perform it. This is only 5% of eligible doctors in your area have even applied for these waivers. And if you have the buprenorphine, it's ways our people could have treatment without having to stand in line, which some people see when people are waiting outside of, let's say, methadone clinics. And they can actually go places and live a productive life without drawing the attention. And we talked about this briefly. Sometimes we have to make sure we educate our clients and to break down the shame and stigma of treatment and recovery. Because asking for help and going to get help, we believe, is a true sign of strength. It's not a sign of weakness. But sometimes it's hard for people to get over that initial shock. And the use of buprenorphine by going to offices as opposed to a treatment center sometimes may bode well for some of your clients. And then again, I'll direct your information or for additional information to page 5, 10, 11, and to the appendices in the toolkit. Seek funding. I'm going to give you this as a brief example because the time is growing short. We started with 3 people in a room. 3 people in a room that had a passion and desire about helping people that were in crisis they came in. No funding was there at first. 3 people in a room thought about what we needed to do, thought how we needed to help our clients, and then we sought for the funding. And the funding's out there, especially now, especially with some of the lawsuits with your attorney generals are suing some of the pharmaceutical companies, and the money is designated to treatment and recovery. Also through SAMHSA grants and other government assistance grants and state and federal. So they're out there, you can provide it. The best thing, and I have to say this, that you have to engage yourself and have grant writers and to gauge for these support services. We partner greatly with our county government and our local government, and we work together to make sure all these services are connected. If you don't have a grant writer, I believe Dr. Marno talked about this earlier. If not, it's in the materials. Partner with local universities and colleges. They may have a passion or an interest in this, and to make sure that you do that. I'll be remiss if I didn't say check the solicitations by SAMHSA and BJA. They're always out there. Make sure that if you stay involved in these, a lot of these come up all the time. Law enforcement. There's law enforcement grants that are out there repeatedly when you collaborate with your mayors, your jails, and your police agencies. They have grants out there tremendously to deal with cutting down on recidivism and cutting down on crime. So partnering with them and actually having meetings with them to see how both programs can work will be critical. And I know Dr. Marlowe talked about getting state block grants and direct appropriations, so I'm going to skip that for the sake of time. And of course, there's additional information in the toolkit. We talked about busing and working on distal goals, but I'll go back to treating the whole person. The reason why you want to treat the whole person is that once people are in crisis or out of crisis, sometimes the latent trauma that actually was the crisis that developed to it is worse than that. So you have to make sure you treat the whole person, give them the treatment that they need, and make sure they have the tools to be successful. One thing, and I'll give a shout out to Jeff Smith, our coordinator for our area. One thing we found out through our research is that people needed driver's licenses. As big as Buffalo seems to be, we don't have good mass transportation. So our clients had a lot of time or have trouble getting back and forth to work, getting back and forth to court, getting back and forth to their agencies and treatment because our bus system or our mass transportation system shuts down at a particular time. Or if you miss the bus, the next bus isn't for another 30 minutes. So we realized that just helping them get their driver's license back was critical. I say that because the employment sometimes is so far away from our individuals that they need that as well so they can get back and forth. I'll be remiss if I didn't talk about family court. Connect them with advocates so they can see their children again. Sometimes, and I know we talked about this briefly, in your distal goals is making that reconnection with your family, making atonement for your family, and that gives them the energy and the support to do well. I see Maureen is popping up, so I'm going to move to my last couple slides because I know I'm running a little over on time. Why use MAT? Medication-assisted treatment is medicine for people that can live healthier and safer lives. We use medicine in our lives every day. If you use high blood pressure medicine, if you use medicine for cholesterol, if you use medicine to stabilize something. So we always use medicine, and this is another form of medicine, and we have to make sure we educate people that. The other thing that it saves valuable tax dollars and governmental resources. We have to educate our legal community, make sure that we're breaking the revolving door of the criminal justice system. And I think that's how we combat the root problem. The root problem is to change attitudes and make sure everyone know that this is an illness and people should not be afraid to ask for help and to seek treatment. And this is a study that we had from over the last couple of years since our program has been initiated with the opioid-related deaths in Erie County. And as you see, once connecting people to medication-assisted treatment, you saw that the death toll has decreased dramatically. And I wanted to highlight and end on that point is that it's medication for people that can live a healthy and productive life. We all use medicine, so it's our job to encourage other people, and especially in our treatment community, that medication-assisted treatment is the gold standard, and it's the way we can help and save people's lives. Thank you, everyone, and I'm going to turn it back over to Dr. McLeod.
Anna, and thank you, Dr. Marlowe. I mean, this is such a critically important topic, and your presentations today have been incredibly interesting and thought-provoking, and I want to thank both of you for taking your time and providing this information with us today. In the Q&A pod and in the questions that we received as you pre-registered, we have dozens of questions that have been submitted, some of which were answered during the presentation, but many of which we'll be able to answer. We don't have the time to do them right now, but we will do them as soon as we switch over to the discussion session. But before we do that, as we're coming to the end of our time here, we want to share with you the main resource that was the topic of today's webinar, that National Association of Drug Court Professionals MOUD Toolkit. So it's available for download. You should see a file transfer box that popped up on your screen. Under file name, click the file and it should turn blue, and then the download button should turn a darker gray. When you click the download button, it should initiate the process to download that directly to your computer. And so please feel free to do that. You can also see a second document that we have for you is the webinar attendance certificate. And okay, there it is. It just popped up in the download box. If you're interested in downloading this for personal use, please do so at this time. And I do want to remind you that if you haven't yet signed up for the GAINS listserv, my colleagues and I encourage you to register using the link that's on the slide, but actually it's kind of hard. Amelia, is there any way to move that file transfer box? There it is, okay. So there you can see the link that appears. If you enter that link into your web browser, you'll be redirected to a site where you can enter your personal information, your contact information, and you can stay up to date on all the activities and the services that are sponsored by the GAINS Center. So we want to thank you for your participation in today's event. If you have any other questions or comments, the GAINS Center direct contact line is provided on this slide, or you can go to the SAMHSA website and put GAINS Center into the search box, and you can see also on this slide is a phone number if you want to go and call us directly on the phone for any information. We are, as we had mentioned earlier in the webinar event, we're hosting a discussion group, a 1-hour discussion group over the next 60 minutes to answer questions that were entered during the pre-registration period, that were entered during the webinar, plus any other questions that you may want to enter during the discussion group itself. So we're hoping you can stay with us for the discussion group. For those of you who have other commitments and need to leave, we want to say thank you and have a great afternoon. But now I'd like to begin our discussion session. So again, we have the Honorable Craig Hanna joining us. We have Dr. Doug Marlowe, and as I had mentioned early on, in our introductions, we're being joined by Sophia Lombardo, who is a certified recovery specialist who can talk about some of the practical applications. And I think we have actually several questions for Sophia. But first I want to start with some questions that were entered in the Q&A pod during the webinar itself. And one participant noted that both Dr. Marlowe and Judge Hanna said, we do not sanction use, we sanction behavior. And the participant asked, could you go over this in a little bit more detail? Can you give some examples of the types of behaviors that might be sanctionable and also the types of sanctions that you might use in response to these behaviors? So Judge Hanna, I'm going to ask you if you would want to start in responding to that question if you're willing to do so.
Thank you, Dr. McLeod. That's an excellent question. One thing that we do, and I think Dr. Marlowe highlighted in his point, we sanction when people do things that they know they shouldn't be doing. Let's say like selling their medication. Let's say like providing unprescribed medications to our clients. But we don't sanction use because use, remember, they have an opiate use disorder. And they're not going to stop using opiates just because a guy with glasses and ties told them to go to a clinic and get some medicine. I mean, that's just fiction. And I'm glad the doctor said that. They're going to use until they get to their therapeutic dose. That's going to happen. Our sanctions are very brief. They're not even more than a day. And I think the doctor highlighted on it. We can't take people off of their medication. If we take them off of their medication, then we're doing worse to them than if they ever came in the program. And I have to explain that to our judges because we have a lot of judges, and I'm glad this question was brought up, thinking that you're replacing one one like drug for another. But we're like, no, this is the accepted practice, the best practice of treating an opiate use disorder, and we do have to constantly drill that into some judges' heads. And I always brag about Dr. Marlowe. Dr. Marlowe is sometimes you have to train a trainer. He trains us so well that sometimes we have to quote and steal from him to make sure our clients and our judges know that you can't sanction someone out of a drug use. The way you do it is uploading and uplifting them and giving them the services that they need. I don't know if the doctor wants to add to that.
Yeah, that was extremely well done. So the basic tenet in behavior modification is that you use low magnitude treatment oriented consequences for what we call distal infractions. If somebody is suffering from a symptom of their illness, and that symptom is a compulsive symptom, if you give them high magnitude sanctions for that symptom, not only will you not make them better, you will actually harm them and make them worse. That leads to what's called learned helplessness. If you're punished for doing something that it's extremely hard for you to avoid, you will increase crime, increase substance use, decrease employment, increase emotional distress. So it basically violates the most basic tenet of behavior modification. So we sanction proximal behaviors, which are willful behaviors like the judge mentioned. So if the person sells their medication, if the person delivers a tampered or fraudulent drug test, if the person goes to another doctor outside the program without approval and gets a second prescription, those are willful transgressions. Those can be sanctioned, but we do not sanction the symptoms of somebody's illness. We treat the symptoms of their illness.
Thank you, Dr. Marlowe. And this might be somewhat of a related question. Another participant asked if there were any statistics available on the extent of these proximal infractions. I guess they're trying to get a sense of the picture.
Is that a question for me?
Well, yeah, let's start with you.
Okay.
I think you might have the larger picture, and Judge Hanna might know about be able to apply that to Buffalo City. But let's start with you, Dr. Marlowe.
So when you talk about proximal infractions, so when people are using their buprenorphine, this usually applies to buprenorphine, if they're using it inappropriately or getting it through illicit means or diverting it, that does seem to happen in about 20 to 25% of cases. That's sort of the incidence of it. It does happen. When we interview people confidentially about why, the vast majority of people that are using buprenorphine when they're not in a way they weren't supposed to or when it wasn't prescribed are usually doing it to self-medicate symptoms of withdrawal or to try to wean themselves off their medication. In other words, they're using the buprenorphine inappropriately because it was denied to them appropriately. So now, I do not have data on how frequently people engage in fraudulent drug tests and some of that kind of thing. That I don't know. I don't have any data on that. But there are very simple ways to monitor and avoid these infractions.
Maureen, just to
Thank
add
you.
on that, we try not to, especially when someone is in crisis, we try not to hold that against our clients. And I think that's as the doctor was alluding to. Our job is to make sure we give them the tools to be successful. In the beginning, until they get to their therapeutic dose, no matter what medication assistance treatment that they're using, people try to balance one. And let's say if they still want to get a reaction from an opioid use. Again, this is someone in crisis. This is someone that's ill. We don't hold it against them. We may have that data, but I don't know unless we're going to share that data. We have that data for therapeutic purposes so we can help them. But I know if let's say if Dr. Marlowe was doing a study on our court, we would share it, but we probably wouldn't share that data because that data is only used for treatment purposes.
Thank you, Judge Hanna. I'm looking at another question that's come into the Q&A pod, and I'm going to step back in our timeline. And this question, this participant asks about the assessment tools that are used for non-clinical staff in their assessment of the need for MAT in making a referral. Are there preferred tools, instrumentation that is used? And Judge Hanna, if you could speak about what you actually use in Buffalo.
Yes.
I don't know who wants to start.
That is an awesome question, and I'm remiss for not putting that into my dialogue today, but I'm glad it was brought up. The assessment tool is critical, and it has to be used, and I can share the one that we use at the onset of the case, because you have to have the individuals that first have contact with them, see them, use the tool so they can actually be diverted to our treatment coordinator so we can do a secondary assessment. It's very critical. I will make sure it's sent to either Maureen or to Amelia so it can be shared with everyone to use. And I'm remiss and I apologize for not bringing it up during my lecture. I don't know if Dr. Marlowe would like to add.
Yeah, I may have misunderstood your question, but you say the tools that should be used by non-clinical staff?
That was the way the question was worded, yes.
So the short answer is non-clinical staff don't do clinical assessments. That's one of the problems in the criminal justice system, is that we rely on very often on pretrial services officers, court officials, probation officers to do the frontline screenings that start the process of who gets to go where. And our research on their competency to do so is very, very sobering in the sense of their ability to administer the instruments correctly, the use of overrides, the scoring of it. So the short answer is no probation department or pretrial services department or drug court worth its salt would have assessments done by anyone other than somebody trained to do assessments. That would either be contracted out, but ideally it may even be some in-house, a social worker, a psychologist, a clinical case manager trained to make these determinations early on, detect people early on. I do list the tools that should be used. They're in the toolkit. They're examples of tools that screen for opioid use disorder. I'm particularly fond of one called the Texas Christian University instrument. Many of you are familiar with its generic tool, but there is one with a special supplement specifically for opioid use. There's also a rapid opioid dependence screen. There are tools that measure craving, symptoms, and withdrawal. But as we talked about people staying in their lanes, and we talked about that in terms of medical providers and court officials. A court official doing a substance use screening is not in their lane. And so the time has come What drug courts have taught us is that neither system alone is competent to do this job. Criminal justice professionals do criminal justice job, and treatment professionals do treatment jobs. And when they don't know which job they're doing, that's when we get the worst outcomes in our system.
Thank you. And so I would certainly direct all of our participants who have interest in screens and assessments to download the toolkit and really take some time to go through the toolkit and see the information that is there. So I have another question that came in earlier, and I think I understand the context behind the question, and I'm going to start, I think with you again, Dr. Marlowe. I mean, you mentioned how in the toolkit you talk about the fact that the participant has the right of choice of medical providers, and you stated very clearly that the selection of meds, dose, duration really is a medical issue. But you also said that the court, if I understood correctly, has the right and responsibility of making sure that that medical provider is following evidence-based practice. And if not, they could seek a second opinion. So this question, if I'm understanding the question correctly, says, does this mean that the treatment court has the authority to restrict participants to specific providers? And that might be related to a court's determination that certain providers are not following evidence-based practice. And in the person who entered that question, if I'm misreading that, please resubmit your question. Thank you. Judge Marlowe, Dr. Marlowe?
So the general principle is the right of choice for the participant. That's the broad go-to principle that individuals do better when they work with the provider of their choice. If the drug court team has substantial reason to believe that that provider is rendering substandard or potentially dangerous care, then the court has an obligation to get a second opinion. And based on the opinion of a second expert provider, may say, you need to work with the second provider because we are finding that that first provider's conduct is either a threat to you or is substandard practice. The point here is that the burden essentially is on the judge, if you will, or the state or the program to make a finding, an explicit finding, not just an assumption. We think this guy's a pill mill. I hear this all the time. These frankly slandering physicians in the community, calling them pill mills and incompetent without any, there's never been any hearing on that. There's never been any specific determination made. There's never been a review from a second physician to say that. This is non-medical staff basically casting aspersions, frankly, on members of the medical community without a finding. We're courts of law. So if you question the competence of the care, then you have a hearing. It may not be a literal whole due process hearing, but there is a finding based on medical evidence. So the exception to the rule is they get to choose their provider. The exception is when there's good evidence and a finding that that care is dangerous, then they get a second provider. It is not the court deciding, well, I'm going to override the provider. I'm the judge. I'm going to decide. Judges don't make those decisions. I hope that clarified that better than I did apparently before.
I know, just to add to what the doctor was saying is that staying in your lane is critical. And we don't make treatment determinations or medical determinations, you know. And I like to say we're the coaches, you know. We're telling the clients, this is what you do. This is the roadmap. This is the roadmap to success and how to engage in a successful recovery. And as the doctor said, when things like that happen, we have to make a determination if that provider is going to be used again. And I will tell you, and just from my own personal experience, if you ever have to cross that road, you would have the other providers probably giving you information. You will have to go and have to service that. But hopefully you never have to cross that road. Just to bring Sophia into this conversation too, is that we get a lot of critical information from our peer and recovery group. And they're out there and they hear things and they may know more than we know about things if we want to have someone investigate how a particular provider is going into it. I don't know if Sophia wants to add on to that.
Yeah, thank you, Judge Hannah. So, I mean, that's the thing, like, because we have the personal experience, so then that also builds a personal connection with the individual, right? So having my personal experience with substance use disorder and how it worked for me, I can help somebody else, you know, telling them what does and doesn't work. And then that also just builds, it immediately builds a connection and a bond, where they want to tell me more about their, you know, more stories about their use, and more than they might tell a probation officer or a judge with fear of being in trouble. So I often get in that dilemma where I'm told a lot of things that can alter, you know, their courts and their stipulations and things like that. But it's building like a close relationship with the law enforcement as a specialist, so that way we can, like, it's about helping and not punishing, and that's like what we try to do. So.
Well, Sophia, now that we have you in the limelight here, I have some additional questions for you, because the toolkit, you know, Dr. Marlowe talked about one of the principles of the toolkit: find or develop peer support groups, also pair the participants with trained recovery support specialists. Judge Hanna talked about the importance of utilizing peer specialists, and you are a certified recovery specialist. And I suspect that there are a number of folks who are listening in on the discussion who aren't quite sure what you are. I mean, what is a certified recovery specialist? So I'm wondering if you could describe the training and the credentialing that was necessary to become a certified recovery specialist, and then if you could also talk about the roles and responsibilities for an individual with your type of credential.
Yeah, of course. So first and foremost, a certified recovery specialist is a little different than a peer specialist. I'm coming from Pennsylvania, so I'm speaking on behalf of, like, the Pennsylvania Certification Board, which is a nonprofit that gives out the credentials voluntarily to people that want them. So a peer specialist specializes more in mental health and co-occurring, whereas my role as a certified recovery specialist, I'm more certified in having my own experience with substance use disorder and being in recovery from that. So to be a CRS, you have to have at least 18 months or more clean, as I like to say, so in recovery. You also have to do, it's 36 hours of trainings. So they could vary from motivational interviewing to screening and assessment. Confidentiality is a big one. Ethics. In Pennsylvania, I'm limited on HIPAA laws here. So I'm very limited on what I can and cannot disclose. Like, for example, I can't say what somebody admitted to using, but I can say that they did admit it. And I can be really broad about it. And then, I mean, I got some statistics about Pennsylvania because I just thought it was really interesting to know that, so Pennsylvania has 1,654 certified recovery specialists. I mean, that's an amazing number. And then that's not even including peer specialists, which is mental health. So I think it's just important to really understand how important it is for individuals to really have somebody they relate to on a different level. Like in my dress attire for work, I wear business casual is what I call it. So I don't want to look like a lawyer or a probation officer. I want to wear jeans and a nice t-shirt, and it automatically makes them more comfortable because I don't look so intimidating. And so I think that's the biggest thing. And then we have to renew it every 2 years. So it's not like, you know, you get it once and that's it. You have to continue to do trainings throughout the 2 years, and then you go through the process of renewing it. The initial time, you have to take an exam after trainings, and you have to get a certain score. There's like 4 areas they test you on. And if you get 4 wrong, you're not able to pass. So And, so yeah, that's like the broad, of what I am and what I do. Primarily, I just advocate. I'm a mentor. I'm a coach, kind of like Judge Hannah mentioned before, like coaching, helping coach them. And yeah, so I think that's about it.
Sophia, what is your relationship with the court team of your local recovery court? How is it that you get paired with individuals, or could you describe a little bit more about the logistics of that?
Sure. So usually what happens is individuals, my personal experience, individuals are involved with the law, and they get drug court or treatment as an option to get out of prison sooner. And so we get brought into that just because all of them individuals have a substance use disorder. And so they send a referral, basically because we can't do a clinical assessment, obviously, like we're not clinical either. So we can't say, I think they need treatment. We can just kind of come up with what they tell us on a personal basis. So they give us a referral, and they just kind of utilize us to have them, just give them extra support through the process, and kind of so that they see firsthand somebody that has gone through the process and has done it successfully, and can kind of guide them along the way. So just being a mentor and building like that close bond with them. And then,
Thank you, Sophia.
yeah.
Judge Hannah talked about the importance of housing, supportive housing and employment, and ensuring the reliability of transportation. Do you assist, or can you assist in any of those aspects of social support? Or is that outside your lane?
That question is directed towards me, right?
Yes, Sophia.
Okay. All right. Yeah. So because I actually also do reentry services, so I personally can help with things like that, whether it's, that's what a CRS is supposed to do regardless. We're supposed to just help the individual succeed. It's the same concept that drug court follows, is anything to help the participants succeed and towards success. So if they need help with a bus pass, then we'll reach into funds and help them with that. A lot of nonprofit recovery organizations have employees who will transport the people to clinics, to their appointments. If you utilize a CRS and find the nonprofit recovery organizations, there's so much help out there that they're willing to do to help one person succeed. So transportation, medical assistance, all that stuff is like what we specialize in. So, and yeah, so.
Okay, one last question for you, Sophia. And this is something that came up during a training that I did several weeks ago. There was a question, it was in a community that recognized the need for working with persons with lived experience, and particularly certified recovery specialists. But in that particular community, they said, but we don't have funding. Do you have any suggestions for a community that would like to have or encourage or promote the use of certified recovery specialists, but is seeking funding for these positions? Where does funding come from in your community?
So I know that we get our credentials through a nonprofit organization. So all nonprofits go through, like Judge Hannah and Doug Marlowe said, it all comes through grants, grant writers, finding people who specialize in courses of writing grants, reaching out to colleges and professors that can help you put a grant together, because there's a lot of people passionate about it, because they might have a family member or a friend that have experienced substance use disorder. So it's just, a lot of it is like local, state grants. And that's how I get paid, is through a grant, through somebody else that just has a passion to help the community in a way, so.
Okay, thank you, Sophia. And let me ask that question, or related question, I guess, to both Dr. Marlowe and Judge Hanna. Because you both are very strong proponents for the use of recovery specialists, what thoughts do you have that you can share about funding for persons like Sophia who are recovery specialists in local communities?
One point I would raise that a lot of people may not realize is that recovery specialists and benefits assistants are coverable under Medicaid in, I won't say necessarily every jurisdiction, but the vast majority of jurisdictions. And a lot of programs don't realize that they can be and ought to be billing for those services. And you can also, they will also cover in-reach services under some circumstances, so that you can intercede with people during pretrial detention or maybe on a reentry and prepare people and get them hooked up for Medicaid and other things. So that's one thing that a lot of people are not aware of that is available to them.
And that's an
And
excellent
Judge
point.
Hanna,
I'm sorry, Maureen.
I was just going to say, in Buffalo, what strategies do you use for funding recovery specialists?
Dr. Marlowe hit the nail on the head that it's coverable under Medicaid. And I have to give a shout out to our statewide coordinator, Dennis Wiley, is that peer and recovery specialists are an essential part of every treatment court throughout our state now. And we're trying to make sure we put that out there to all our advocates, all our judges, that it's an essential part of every treatment court. And they are one of the most important players on our treatment and recovery team. So obviously I'm a sports nut, so they're the Wayne Gretzky because it's hockey season, or the LeBron James because it's basketball season of your treatment team, and they need to be involved in each and every aspect of your treatment recovery meetings.
Thank you, Judge Hanna. I like the sports allergy, wrong sports or wrong teams, though, I would have to say, just in my opinion. This is also for you, Judge Hanna. Somebody said, could you expand upon your reference to the wellness checks in Buffalo? How do you conduct those, and what do they entail? Could you describe them?
I'm glad that they asked, because a wellness check, I think as Dr. Marlowe knows, is a misnomer on our part. It's really making sure the person is doing what they're supposed to do. And that's in partnership with our local law enforcement, our police, and our sheriff. Like sometimes we just do random checks and make sure they're home and doing what they're supposed to do. I'm going to use a vernacular. There was a song out in the 80s called "The Freaks Come Out at Night." So we want to make sure our clients aren't hanging out with any freaks after 8 o'clock. Because we know if you're in the treatment community, it's the company that you keep. How are you going to be clean and expect to stay clean if you're hanging out with people that are using? You don't want that desire or that temptation around them. And the odd part about it is some of our clients have to choose different friends. And it may sound harsh, some of our clients have to choose different family members because it's the people that they associated with for so long. And our wellness checks, and again, it's not a wellness check, it's to make sure you're doing exactly what you're supposed to do. And if you're not, then we have a teachable moment, as Dr. Marlowe said. You're going to be the topic of the next class, the next session. I'll give you a brief example, but I won't use the party's name because we have to protect the innocent if you ever saw Dragnet. There will be the topic of our next discussion when everyone's in there. And the beauty of it is, and our recovery and peer advocate was standing right behind them and said, listen to them because they're trying to give you something. You cannot hang out with people that are using and expect to stay clean. I mean, it's just not going to happen. It's just an impossible proposition. So the whole idea is that we want to make sure that we see them at night when they don't know we're coming, and you get a very good thin slice of what they're doing when you're not around.
And could you tell us who is actually conducting these clandestine visits?
Okay. Our law enforcement partnership, our sheriff's department, our police department, our probation department, they're going and knocking on their door and checking on them. And again, as we said this before, this is not for punishment, it's for therapeutic. So we're not going to hold it against them. They're not going to go to jail the next morning, but we will have a discussion about their choices. So.
And there have been some recent studies of the best way to conduct home visits by apt associates and some other organizations, kind of what to the do's and don't do's when you go to people's homes. I would strongly recommend that that the audience look those up. The Journal for Advancing Justice, which is our journal, has a special issue recently where we publish a lot of that research. So using what's called core correctional practices when you're there, using motivational discussions and other things, instead of going in there and tossing the person's house looking for drugs. You know, one's therapeutic, the other is anti-therapeutic.
Thank you, doctor. That is a very good suggestion, and I'm glad he brought that up, and that's why I love working with him, is that the whole idea is that you're uplifting people. You're not trying to punish them. So.
Okay, so somewhat of a related, perhaps, maybe not so much, question is if either one of you or anybody could talk about innovations in terms of technology use related to monitoring participants in recovery court. And I'm not quite sure what ground is being covered there. It was somewhat of a broad question.
If I can pivot from that question a little bit, we have embraced technology with our clients that are doing great in court. Even though best practice says a lot of times our clients enjoy coming to court, it might be the highlight of their day, but let's say someone is well within their recovery and coming to court and coming to treatment and missing work might be an impediment to them doing well in work. So we have embraced technology where they can actually check in with the whole team via Teams. And I think that's a beauty. That's probably one of the best takeaways. We didn't talk about it of COVID over the last year and a half, is that we have to embrace technology with not only with our check-ins and not only with our treatment meetings, but also it may work better when people are doing so well in their recovery that coming to court once or twice or 3 times a week may actually hurt them, because we want to make sure we keep them on the path of recovery. I don't know if Sophia, the doctor, wants to add.
I can add real quick because I know that recently there was actually a grant approved in Lancaster County, Pennsylvania, where we're going to end up having a recovery app. So basically, it's an individual that might not feel comfortable in person admitting their problems and going through the recovery plan and the recovery scales, all the measurements to determine where they're at spiritually, mentally, emotionally. So now there's going to be an app where they can instantly connect with a peer specialist anonymously if they want to. I think that's super beneficial for the people that are not quite ready, but they're interested. And I think that's an open doorway to get more people in. So
I would just add in terms of the tech, I'm not sure if this is what the question was getting at, but to the extent that technology is being used to enhance medication compliance, safety, there are apps that send reminders to people when it's time to take their medication. They then use the facial recognition and or thumbprint recognition, contact their probation officer, or their probation officer contacts them or the treatment provider, and they take the medication on camera. And so there have been a number of studies showing this is not with people in drug courts, but in people in substance use treatment and mental health treatment, greater medication compliance when there are these automatic check-ins with observed administration. There's also I alluded to this. There are these specialized caps that go on their medication jars. So the vial, when you take off the cap or open the cap, it records the time that the vial was open. It records how many pills were taken out at that time, and that's actually recordable. So if somebody's taking 5 pills out at once when they're not supposed to be, or they didn't take it out when they were supposed to, there's a record of use. So again, these can be used in the early stages for the team to feel a little bit more confident in the reliability of people's medication adherence. I'm not sure if that was what the question was getting at.
But that's incredibly useful information for those participants in the discussion group who are not yet familiar with those types of technological advances, that there's a place where they can, or can you recommend where they can go to find out more about this?
Yeah, I mean, I tend to, always get myself in trouble when I start mentioning, for-profit products because, given my kind of my role at NADCP, that doesn't sound like, it sounds like we're sort of endorsing a particular product. So what I could do maybe is give you a list of products that are out there that I'm aware of and that people could, go link in it. But the reality is this wouldn't be hard if you just did a Google search to find medication compliance applications in corrections. But I really don't want to mention a product in this context.
No, and I appreciate that. So Google medication assistant compliance, do the Google search, things will pop up. Okay, now we have a clinical question. So this has got to go to you, Dr. Marlowe. How do you suggest that a treatment court team respond to a participant on MAT who's using other substances? For example, a client on injectable naltrexone who starts using methamphetamine or cocaine while receiving MAD.
So the analysis I alluded to earlier regarding opioids is a generic analysis for behavioral consequences in drug court. The question is whether a behavior is proximal or distal. So if somebody has an opioid addictive disorder and they then are switching to a new substance that they are not clinically addicted to, if there is no compulsive use of that other substance, then it's a proximal behavior. The question is whether the person is clinically stable or not. So this is really, in other words, I don't want to give you a single answer because it all depends on what the physician says about the person's clinical status. The person says the person is stabilized and you are testing for opioids on board, and all of a sudden they start using methamphetamine, for example. That's an effort to avoid the test. For somebody who's clinically stable, that's a proximal infraction. You treat it like any other willful effort to elude detection. On the other hand, if the person's still unstable clinically, they're suffering cravings and withdrawal, and they are, in an ill-conceived way, trying to treat withdrawal by switching drugs they think won't have a blockade, then you treat it as a clinical issue. I'm not sure if I mangled that too much, but the point there is, the question is for the physician, is their drug use compulsive or is it an effort at avoiding detection? I would point out, by the way, that recent studies are beginning to suggest that naltrexone, especially the injectable long-acting version, especially when mixed with blanket of its bupropion, I forget, or propanol, I forget which one, seems to have potential effects for reducing methamphetamine cravings and response. So there may actually be unlocking a medication. And so somebody who was trying to get over on things by taking methamphetamine when they're on naltrexone might actually outsmart themselves and not be particularly successful at it. So you want to find a physician who is better qualified to think about if methamphetamine comes on board, it may be time to add an additional medication to treat the
Well, a related question with maybe the same, maybe a different response, and this would also be for you, I believe, Dr. Marlowe, says with the surge of states legalizing the use of medical and recreational cannabis, do you foresee any problems with participants using medical cannabis while in drug court programming, such as MAT?
So the medical, so first of all, the toolkit that we developed, the principles we developed don't apply to cannabis because they talk about lawfully prescribed medications. And since marijuana cannot be lawfully prescribed, this doesn't apply to that. The general position on medical marijuana is that there needs to be an independent medical evidence of whether this is medically indicated. If somebody has their own certification elsewhere and the team has reason to believe that that was provided in a in a sort of substandard context or is inappropriate for the patient, the team can and indeed ought to get a second opinion. The simple reality is, I'm speaking exclusively for myself here, I'm not speaking for NADCP. If you review the research evidence on the medicinal value of marijuana, you can name the number of conditions that it has any evidence of efficacy for on one hand, and you wouldn't need all 5 fingers. And so there can be a medical determination that somebody does, needs medical marijuana, then that should not be an exclusion for the drug court. But getting a second opinion about whether someone with an addiction history and an active addictive disorder taking marijuana, you would be hard pressed to find any scientific evidence anywhere that that would be an appropriate medical decision. But you don't make that decision yourself. You make it based on competent medical expertise.
Thank you. This question I'll just throw out to the group, whoever would like to address this. How does the court system ensure culturally sensitive approaches and substance use services to marginalized communities, including indigenous populations?
That's a good question, and I think the best part about it, or the most effective way, is at the inception when people are actually screened and transferred into drug courts. So I guess with people that wear the hat that I wear, they have to make sure that they're not, people that are getting referred to drug courts are as equal and as fair as others. I do hear stories about some people of some ethnicities getting sent to drug courts and others haven't. But I think the beauty of what we're doing here today is we're having these uncomfortable conversations and we're learning best practices. And when that happens, we have to alert our supervisors and our treatment professionals to make sure it's not happening. I've heard things about how certain people or certain ethnicities go into certain type of treatment courts, but our job is to make sure that the people that sit like me, that are referring people to treatment courts, are treating everyone fair and adequately.
Judge Hanna, you don't partner. I'm just thinking about the St. Regis Mohawk lands up they're in Franklin County, so they're not part of your judicial district, where there's a partnership between the governmental entity in Franklin County and the St. Regis tribal population, tribal nation, in terms of how they work with individuals who are referred to recovery court. But that's not part of your judicial district, Judge Hanna, is that correct?
No, that's not part of our judicial district. We do have the Mohawk and the Seneca tribal nations in our, I was just speaking in general as, let's say with any ethnicity or population, that it could be questioned about who's being referred and who's being accepted in our treatment courts. And our job is to make sure that anyone that needs that treatment is going to be accepted regardless of their ethnicity. I know the doctor was about to add something.
Mm-hmm.
Well, I was just going to say that we've been focused on the issue of racial, ethnic, and cultural disparities in drug courts for a few years now, and doing a lot of research on this. And there's no question in my mind that there are substantial disparities at every step along the entry pipeline. Individuals, for example, African American and Latinx, especially males, are more likely to be arrested for drug offenses, but far less likely to be ever referred to a drug court in the first place. Among the ones referred, they are far less likely to get into drug courts, and among the ones getting in, they're far less likely to graduate. Question is what's responsible for this, and what fixes it. And there do appear to be a number of factors that are associated with those things disappearing, those differences disappearing. The first that seems to be associated with it is having staff member in the drug courts who come from the same communities of origin and have come from the same cultural backgrounds. And having services located sort of physically in the neighborhoods where the participants live, so they don't have extra travel burdens. The use of culturally proficient services. When I say culturally proficient, I mean a service that brings cultural disparities into the treatment as a core component of the treatment. So there's something called HEAT, Habilitation, Empowerment, Accountability Therapy. It's specifically for African American males between 18 and 29 years of age in drug court, where it brings issues of racism, historical trauma from slavery, Jim Crow, counterproductive messages in hip hop culture. That is all part of the treatment intervention. And when delivered, not only do these young Black men have as good outcomes as other people, they actually have the best outcomes in the drug courts. So the reality is that we have a lot of work to do to fix ourselves. And I don't think we as a field, and when I say we as a field, I mean drug courts, but the entire criminal justice field has been willing to look under the rock that we need to look under. And we need to take this as our probably our most sacred obligation that we have not risen to yet, but we are rising.
And I'm glad that
Dr.
Dr.
Marlowe, if one of our participants were interested in learning more about the programming in communities that are using this HEAT model, could you direct our audience to a particular community or to some research that's available on this topic?
Absolutely. I can also send it to the Gain Center folks if you want to send it out. I did 2 pilot studies of HEAT, one in Indianapolis and one in, oh gosh, I forget, in another state. And I just received a grant to do a randomized trial of HEAT, so we're working on it now. But I do have some studies, a published paper I can share. HEAT is being used all over the country. It's used in jails and prisons. It's used in reentry programming. We are working with a HEAT study in a gang unit in Portland, Oregon. I mean, Portland, Oregon, of all places, probably has the worst street violence activity and gang activity anywhere in the country at the moment. And we're using HEAT in the gang unit there. And during COVID, it was an online HEAT group. So we can definitely put people in touch with programs all over the country that are using it. But again, if you were to just simply Google habilitation, empowerment, accountability, therapy, you would get the Pinwheel group, which is the group that
I'm sorry, could you repeat that? What HEAT stands for, please?
Habilitation, Habilitation, empowerment, accountability, therapy.
Thank you.
And the reason I put so much time and energy into HEAT is because everybody talks about we need culturally proficient treatments. Well, good luck finding them. We talk a lot in our field, but when you go out and look for evidence-based, manualized interventions for these populations, you'll be very hard-pressed to find them. And I think you were commenting on Native American tribal populations. I think the same applies. They have a lot of specialized treatments, but there hasn't been any research on those treatments.
And Maureen, if I can add, and I'm glad the doctor elaborated on that, it's not just the referral to drug court, it's the retainment. If you don't have culturally sensitive material or culturally based material, someone may be getting kicked out of drug court just because they're not being, responding the way, let's say, a certain drug court judge wants. So that's why everything has to be based on culturally sensitive material. Because I think retainment is probably the bigger reason. They might get referred, but if they get pushed out of the court because, let's say, they may not be responding, or someone may think their attitude is not right, or the way they dress, or their diction, or their accountability is looked as improper. I think that's what the doctor is hinting at, that our treatment tools have to be culturally sensitive as well.
And this is
Thank
not
you.
a drug. This is not a drug court problem. This is at every level of not just the criminal justice system, but the same thing is true in the substance use treatment system generally in this country. That there are much lower rates, success rates among certain racial and ethnic groups for all the same reasons. When programs adopt evidence-based cultural practices, the discrepancies disappear.
And Sophia, could we loop you in again? Have you had experiences using various techniques in terms of retention of clients in recovery? Or could you talk a little bit about what you've observed, what you've used, and the successes of different strategies?
Sure. That's a good question. The biggest thing I think is education, just making sure that not only ourselves, but everybody else is educated on what even addiction is and what recovery looks like. knowing the difference between the choice and the disease. I think a lot of that has to do with, I mean, I think a lot of it is stigma too. I think a lot of people reoffend or whatever because of the stigma still out there, which is crazy because we're in 2021. So you would think that it wouldn't be out there, but it is. And I think trauma-informed care. So I know I've taken personally a lot of trauma-informed care trainings. I think that's huge, is like how, you know, they brought up how you approach the door when you're doing a search, and how you approach racism. A lot of that is being trauma-informed and not re-traumatizing somebody, and trying to help them, you know, get better. So I practice the same techniques, just being informed in trauma, because I think that's a big part of it, that has a lot to do with the brain and everything like that. So I think just important trainings like that, and how to like communicate effectively. Word language is super important. How, you know, not saying you're an addict, like saying person in recovery, you know, individual that has a substance use disorder. I don't even like the word disorder, honestly, but that's just me. So, you know, just recognizing how we talk to them personally, and how we talk separately from them professionally, like keeping that two different things, like how we talk about them and how we talk to them, I think is a big thing too. I hope that answered kind of, sort of.
Yeah, thank you, Sophia. And either Judge or Dr. Marlowe, did you want to just follow up to kind of bring this question full circle?
Doctor, you want to go first?
Or are we okay on that one?
Is it, when you say full circle, you mean sort of connecting the MAT issue to the cultural issue?
Yeah, just kind of, before we move on to the next question, is there any last comments you wanted to make about cultural sensitivity and recovery?
I think I beat that to death with my answer. I think it's the most, I mean, you know, the biggest sins of drug courts and frankly, the entire criminal justice and treatment system in this country is the failure to address all of the isms, you know, racism, sexism, genderism, all of it, and the failure to follow the science when it comes to evidence-based practices, and for people to feel in a public health setting that their personal beliefs were more important, their personal prejudices were more important than following the evidence. And I just think that we need to be better than that. So you didn't, you know, I'm sorry if I'm just, you know, preaching, but, you know, you asked for it.
Maureen, I think the doctor hit the nail on the head. Is that we have to step out of ourselves and be a little bit better than what we are. Because I know I have my own biases or mores about people looking me in the eye. And then I've been to treatments and trainings that in certain cultures, it's the ultimate sign of respect when they don't look you in the eye. So we don't know how ignorant we are about certain cultures and certain practices. So we have to keep learning and relearning and keep educating ourselves. So I thank the panel and the group here for asking these uncomfortable and difficult questions, because that's the only way we'll benefit and truly learn and practice better practices for ourselves.
Thank you, Judge Hanna. We've got one question, Dr. Marlowe. I think this is a quick one. It says, can Dr. Marlowe cite the home visit research again, please?
So there's been a number of studies. Like, again, maybe I'll send you guys at PRA lists of the publications, but we have a journal called the Journal for Advancing Justice. It's published by NADCP, and you can download it for free, Journal for Advancing Justice. And in our most recent issue, there was an article that really talked about the do's and don'ts of home visits. It's just a great article. I think Walter Campbell, I think, might have been the first author. But it's just it reviews how, you know, the home visits work when they're done right and make things worse when they're done wrong. And so now I was just pushing what the judge was saying. It's a welfare check, not a compliance check. It's not a police raid. It's we're making sure you're living in a safe environment, you know, meeting. So Journal for Advancing Justice. It's our journal. You can download it. Doesn't cost a penny.
Thank you. Well, I just looked down at the clock. I'm almost shocked that the entire hour has gone by. And this has been such an enlightening conversation. I'm going to ask Amelia. First of all, I want to thank Dr. Marlowe and Judge Hannah. I want to thank Sophia. I want to thank our ASL interpreters for the work you've done here. And Amelia, I'm going to ask you if you could once again, if it's possible, put up the NADCP toolkit link and the certificate of completion. We have a few folks who say they were not able in the time that was allowed to download it. So, okay, so the file transfer box is again up. So those of you who, here's the toolkit. So you click on the name of the file, and there's the webinar attendance certificate, and you should be able to download both of those items if those are things that you're interested in. I want to thank absolutely everybody who pre-registered for the webinar today and those of you who continued to the discussion group. I think, and we did not get to, there's 2 or 3 times as many questions that were submitted ahead of time than we were even able to get to. This is clearly a conversation that must continue to take place nationally and within our own communities. So I want to thank everybody. It's now 4:01. And Amelia, can we keep this up another minute, or do we need to sign off now? Amelia?
Yeah, everything can stay on for just another minute here. Once I close the room, everything will be gone, though.
Okay. And as Amelia put in the chat, if you weren't able to have to download the toolkit or the webinar attendance certificate, you can just email us at PRA and we can make sure that we can get that for you. That's not a problem at all. So thank you for these really wonderful questions that you submitted. Amelia, any last words on your end?
No, just thank you all so much for your engagement today. I think we had a really wonderful presentation and discussion group. So thank you all so much. Panelists, attendees, we really appreciate your time.
And thank you, John Berg and the Center for Substance Abuse Treatment and SAMHSA for making this possible.